So I am very excited to have our keynote speaker coming up next. Dr. Elena Stoffel is a gastroenterologist. She's an associate professor and director of cancer genetics at the University of Michigan. And she focuses much of her clinical and research time on inherited cancer risk assessment and prevention. She is also the past president of the Collaborative Group of the Americas for Inherited GI Cancers. And today she's going to be giving us a presentation on cancer prevention in Lynch syndrome. Thank you, Dr. Stoffel.
Thank you. Thank you so much for your kind introduction. Thank you to Dr. Patel for inviting me to be here with you today. And thank you all for being here on this beautiful day to talk about the road ahead in Lynch syndrome. And by way of disclosures, I have to disclose that I am from University of Michigan. And if any of you have ever been to the big house that holds 110,000 people, I encourage you to come visit. So go blue. You heard a little bit about Family G, and Dr. Aldred Warthen in 1913, who was a pathologist who practiced at University of Michigan, was one of the first people to actually write up what later became to be known as Lynch syndrome. And this was basically based on a story that a discussion that he had with his seamstress, who was very distressed because she said, everyone in my family seems to get cancer. And certainly in the family tree that Dr. Warthen drew out, certainly it looks like in each generation, about half of people develop cancer diagnoses. And these cancers were overwhelmingly gastrointestinal cancers and uterine cancers. Many years later, Dr. Henry Lynch, who was also studying families all over the United States with a predominance of cancer, traveled to Michigan, had attended a family reunion of the original family described by Warthen, now known as Family G, and actually documented a family history that included almost 900 individuals in the family. And it was through work like this, with partnership between clinicians and families, that we actually discovered the the basis of why Lynch syndrome cancers develop. And as you heard in the previous presentation, the DNA mismatch repair genes were identified in 1992. So that's been about 30 years during which time we've been able to pinpoint what is causing Lynch syndrome. But there's still a lot of work to be done in figuring out, now that we know what causes Lynch syndrome, how do we figure out how Lynch syndrome cancers develop? How are these cancers different from the garden variety cancers that affect many of our friends who may not necessarily have Lynch syndrome? And how can we more effectively treat and prevent tumors that affect families with Lynch syndromes? What have we learned about what works well versus what works not so well? And what tests can we confidently recommend for screening and surveillance? And how often do we need to perform these tests for them to be effective? Also, a bit more about primary prevention. A lot of the focus of cancer research has focused on how do we treat the cancers. But I think there's growing interest in how do we actually prevent these cancers from developing in the first place? Are there medications that may be effective? Are there new immune-based treatments like vaccines that could be effective? And what do we know about health behaviors that we can actually do ourselves that can reduce our risk for cancer? And how do we more effectively identify at-risk individuals? And just to build on the previous question about the Amsterdam criteria, which used to rely on having families that had 3 relative colon cancers diagnosed in at least 3 individuals spanning 2 generations, with at least one of them diagnosed under the age of 50. These were the initial criteria that were used to try to help identify what families might have DNA mismatch repair gene alterations that are heritable through the family. But the reality is that these families were just the tip of the iceberg. And a minority of families with Lynch syndrome actually meet Amsterdam criteria. And many more families, as you saw in the previous presentation, don't have this striking cancer history and could certainly be missed if we just relied on Amsterdam criteria to identify who would benefit from genetic testing. So back in 1995, based on just a few dozen families with Lynch syndrome, groups in Europe actually estimated cancer risks in Lynch syndrome. And this is where we got our original numbers about the lifetime risk for colorectal cancer being, almost 80%, lifetime risks of endometrial cancer being close to 50%, as well as a statistical increase in cancers of the stomach, biliary tract, urinary tract, ovary, and even pancreas. But as time has gone on, and we've gone from having dozens of families with Lynch syndrome to literally thousands of families of Lynch syndrome, European groups such as the Centers contributing to the Prospective Lynch Syndrome Database have done more precise calculations to try to identify the cancer risk based on which gene is altered. And as you've heard before, we like to talk about what flavor of Lynch syndrome does your family have? Is it MSH2? Is it MLH1? Or is it MSH6? Or possibly even PMS2, which at the present time we think is a much milder version of Lynch syndrome with lower lifetime cancer risks. But I think this information is really important because it differs for every family, and these are just the aggregate cancer risks, but it can differ by family, and we're learning that it can be differ by other exposures and other genetic modifiers, as you heard in the previous presentation. So what can we do for families with Lynch syndrome? Well, back in early 2000s, so 25 years ago, in data from European families that were diagnosed with Lynch syndrome, individuals in these families were approached and they were offered colonoscopy. And some people in these families actually said, yes, I will go ahead and I want colonoscopies. And some individuals in these families said, you know what, I'll pass. I don't really want to have a colonoscopy. And in Finland, following these families over time, they demonstrated that people who adhered to a schedule of colonoscopies at least every 3 years were 65% less likely to die from cancer than those that didn't adhere to colonoscopies. And I think that this was really important because it showed that we can actually do something that can reduce the cancer risks in families with Lynch syndrome. However, what is very important to say is that colonoscopy, one of the things that we've learned is that colonoscopy doesn't offer 100% protection against colorectal cancer. And as a gastroenterologist, this is one of the things that basically keeps me up at night, is that we have seen that despite our best efforts to be able to do colonoscopies as carefully as humanly possible to find those polyps before they become cancers, some people still develop cancers despite the fact that they're having regular colonoscopies. And I think that one of the things that we've learned about these cancers is that these cancers are actually different from the cancers that develop in the average colon cancer patient that we see who doesn't have Lynch syndrome. These cancers can often be smaller, and when we catch them through doing serial colonoscopies, they are caught at the earliest stages, and they are very treatable and very curable. So why is this happening? And as you saw in the previous slide, what we've known since the 1990s with garden variety colon cancer is that it takes about 10 to 15 years for a colon cancer to go from a polyp to a cancer. And generally, polyps that are smaller than 2 centimeters very rarely have cancer in them. But the story is different in Lynch syndrome. We actually see that these cancers can develop really quickly, and you can have a very small polyp that actually has invasive cancer in it. And so why is this happening? Well, our previous presenter basically introduced the concept of the fact that the genes that are responsible for Lynch syndrome actually are responsible for fixing errors that happen when DNA copies. And so in the setting of this defective DNA mismatch repair, tissues tend to accumulate mutations. And one of the interesting things is that these mutations accumulate more frequently in tissues that replicate and divide rapidly, which happen to be tissues of the gastrointestinal tract and tissues of the uterine lining. So once these mutations accumulate, these cells actually get mutations in some of the key areas that regulate growth in the cells. And so I describe it as kind of like, this is like if in your car, you lost your brakes, you lost your emergency brakes, and you got your accelerator stuck. So you've got cells that are actually growing very quickly out of control, and they're breaking through barriers. And that's what cancer is. It's basically when cells are not respecting the barriers that that's supposed to be doing. So people have really started looking in Lynch syndrome is why do these cancers develop this way? And what we've realized is that in most colon cancers that happen in the general population, you go from normal tissue to polyp to cancer. But in Lynch syndrome, it's also possible to go from normal tissue to dysplastic crypt tissues that are never going to form visible polyps, and they just go directly to the cancer stage without bypassing the polyp phase. And so in this cartoon basically shows us that if we're relying on colonoscopy to find polyps and remove these polyps before they become cancers, we may not be able to see these dysplastic crypts that are developing without a polyp and that are going directly to cancer. So this has led to a lot of debate that's happening in the international community right now, which is that we know from talking to our patients that colonoscopies are not your favorite thing to do. And as a gastroenterologist, I completely accept that, and I am with you on that we don't want to do more colonoscopies than we actually need to do. But what is the ideal timing of colonoscopy for families with Lynch syndrome has become a topic of debate. You may have heard that there are some differences in guidelines now as to, depending on which gene you have, when do we start colonoscopies and how often do we do them? But in certain countries in Europe, countries are starting to kind of weigh the benefits and say, well, is our goal to prevent all colon cancers in Lynch syndrome, or do we just really need to just catch them early? And I think that's a discussion that is really important to have between clinicians and patients and families as we're taking care of, is what are we trying to do here? What do we think we can accomplish? And what are the costs versus the potential benefits of doing colonoscopies more frequently, with the hopes that we may be able to prevent the vast majority of colon cancers, but perhaps not 100% of them. So how can we do better? I've told all of you that colonoscopy is very effective at finding polyps and removing them and thereby preventing colon cancers, but it's not perfect. So are there things that we might be able to do in addition to colonoscopy which can help us either detect these lesions early or possibly even prevent them from developing? And we know now that there's lots of colon cancer screening options out there for people who don't have Lynch syndrome. So for the average risk individual, there are blood tests, there are stool tests. At this time, the only test that's approved and of proven benefit for reducing colon cancer risk in people above average risk or people with Lynch syndrome is colonoscopy. But are there additional parts of these other tests that could be used, applied, or maybe even modified to help us find individuals who would benefit from more frequent colonoscopy? And so we are really, I am honored to be part of a research study that's funded by the NIH in collaboration with Dr. Sonia Kupfer from University of Chicago and Dr. Faye Castrinos from Columbia, that's actually looking at this precision screening approach for Lynch. Which we called Fit for Lynch. And the goals are to determine the performance and acceptability of stool tests as part of surveillance for individuals with Lynch syndrome, and to evaluate surveillance strategies that may incorporate some of the findings that we find on colonoscopy or other elements of individuals' personal and family history to help find the best interval for colonoscopy. And perhaps for some families, instead of recommending colonoscopy every year, perhaps we may be able to feel confident saying that maybe skipping a colonoscopy 1 year might be okay. But I think that until we do these studies that actually demonstrate that something is safe, we feel very nervous about lengthening those intervals between colonoscopy because what we've learned so far. So there's a lot of research going on in this space, and as many of the folks who will talk to you today, as well as the people, the exhibitors out front, there are lots of studies that are looking at, are there ways that we can think differently about how to pick up markers for early detection? And I know that University of Colorado is one of the sites for the National Cancer Institute's Vanguard study, which is going to be looking at how these multi-cancer early detection tests can be of benefit in individuals who are at average risk for cancer, as well as families that are at increased risk for cancer. And so we're really excited to see where this research is taking us. So in terms of, you'll hear from speakers in the next session about how we're going about reducing the morbidity and mortality from not only colorectal cancer, but also other cancers in Lynch syndrome, like cancers of the gynecologic tract, the urologic tract, and other cancers of the GI tract. But I think that where we are going in the road ahead is going to be going towards precision surveillance and primary prevention. What can we do now? What have we learned? And I think that one of the things many of you may have heard about is the role for aspirin in prevention of colorectal cancer. And it's been a long story that has stretched over decades. But we now know from data from European studies that aspirin use for at least 2 years seems to be associated with a significant reduction in risk for cancers for families with Lynch syndrome. And we know from a recent extension of this study that aspirin doses of as little as a baby aspirin a day, so 81 milligrams, appear to be very safe and could actually have a real benefit. So for individuals who are younger than age 65, who don't have a contraindication to aspirin, this is one of the things that you should talk with your doctors about, because the evidence is starting to be pretty impressive. And what else are we doing? Well, one of the exciting things is that in the past few years, as I mentioned, attention in the cancer space has expanded beyond cancer treatment to cancer prevention. And so in collaboration with the National Cancer Institute's Division of Cancer Prevention, there is a clinical trials network now that involves multiple institutions, including the University of Colorado, that are looking at new approaches to try to prevent cancers in families with Lynch syndrome. And one of the things that we're extremely proud of is a vaccine trial for patients with Lynch syndrome, with the ultimate goal of trying to identify ways to leverage the power of the immune system to prevent cancers from happening. And this study is led by Drs. A.J. Bansal from University of Kansas and Dr. Eduardo Villar Sanchez from MD Anderson. And I am so excited to report that in collaboration with all of these centers, we've actually completed enrollment for the over 140 people who have been part of this clinical trial. And I know that many of you in this room may have been part of this clinical trial, and we're so grateful that this is going to help us move the ball forward by looking at whether or not this vaccine, which is prompting immune responses to 3 proteins that are found in most colon cancers, we'll be able to see if we can actually prime the immune system to try to recognize colon cancers before the elements of colon cancers before these cancers develop. So we're really excited to see the results of this study. It usually takes about 2 years since the last patient's enrolled before we can actually make any reports, but every step forward moves the ball forward. And I think that why are we so excited? I've talked about immune system and vaccines. Why are we so excited? Well, we've been talking about how are Lynch cancers different from garden variety cancers that develop in most people in the general population who don't have Lynch syndrome. These hypermutated Lynch neoplasms really are very visible to your immune system. And the word neoantigens is going to become a buzzword going forward because these Lynch cancers make very, very unique proteins that are very visible to the immune system. And when you look at the immune system of individuals with Lynch syndrome, you see a lot of these T cells that are starting to become very active and trying to catch some of these cancers before they develop. So how can we leverage that? And I think as a next step, I told you about the first vaccine trial, which is basically against just peptides that we see in colon cancers. But perhaps there's a way to leverage this information that we know about Lynch cancers to develop vaccines that may be able to protect not only against colorectal cancers, but other cancer types as well. And so Dr. Eduardo Villar from MD Anderson, who was instrumental in the first vaccine trial, is also working on is also leading work in another vaccine trial, which is called NEWS 209. And this is a novel vaccine that's comprised of 209 neoantigens that are common across many different types of Lynch syndrome tumors and that have also been identified in many different Lynch syndrome families. And the thought is that by developing a vaccine that can recognize components that are common across cancers and across families with Lynch syndrome, this might be an even more effective way to boost immune response. And so certainly every study starts to look at first, what is the safety of this? And then how effective is it in helping the immune system recognize things? And then ultimately, the final goal is to say, can we prove that this has benefits for preventing cancers? And the immune system is very, very exciting because as many of you may have heard, even if you watch the evening news and look at commercials that come on during the evening news, we know that approaches to treating cancers are changing tremendously. And that in addition to traditional approaches that involved chemotherapy medications that were intended to poison rapidly replicating cells in the body, there are now immunotherapies that are focusing on boosting our immune system to be able to boost that host versus tumor response. And this study that was just published earlier this summer in the New England Journal of Medicine was a study that was conducted by investigators at Memorial Sloan Kettering Cancer Center, where they said, let's think about a different way to treat cancers, and let's treat these hypermutated cancers by using immunotherapy, by using immune checkpoint inhibitor therapies. And the caution here is that this is a very preliminary study with very limited follow-up. But I think one of the very exciting things is that for folks with these hypermutated cancers, not only hypermutated colorectal cancers, but colon cancers as well as some other cancer types, some of these cancers were melted away with immunotherapy alone, and that it may ultimately be possible to change the way that we treat these cancers and possibly minimize some of the side effects of cancer, both from cancer treatments as well as from cancer surgeries. So this is really exciting work that we're going to learn a lot more about in the next few years. But what can we do today? And I think the talks in today's symposium are going to be really fantastic because they're talking about how we're building upon what we've learned over time, what we've learned in cancers in the general population, and what we can do today. And the question I always get from my patients is, what can I do today? What can I do about my diet? And certainly in collaboration with Dr. Martina Cavestro, Dr. Patel and I have the privilege of working with her on this study, which relies on cancer patients and families to tell us, what have you done for your diet over the past few years? And are there things that you're doing differently now so that we can try to help map, are there particular things that we can identify as protective versus potentially harmful with regard to cancer risk? And this was prompted by Dr. Cavestro's observation that in Italy, colon cancer rates in northern Italy among young people are much higher than colon cancer rates in southern Italy. And she said, well, we know that the southern Italians eat diets that are richer in fresh fruits and vegetables, and the northern Italians tend to eat a little bit more red meat and dairy products. And so what do we know about this? And can we actually pinpoint why some of these differences may be? Could it be something with diet, or is it something with other environmental factors. And certainly we know in the US, there's vast differences in the incidence of colorectal cancers under age 50, depending on the state that you live in. So there's probably some sort of diet environment interaction. So what else can we do? Well, there's a lot of research that people are getting very excited about. And we know that healthy diet and exercise are good for us. But how can exercise actually prevent cancers? And folks at MD Anderson are doing some really exciting studies that are helping us get healthier with exercise that's good for our cardiovascular system, but we also know it's good for the rest of us too. So, this diagram basically illustrates where we go from learning about how a disease develops to finding effective treatments for that disease, and then for implementing that treatment and making sure it reaches everybody who might possibly benefit from the disease. And we talk about things going from bed to bedside, for treatments from going from bed to bedside, that takes about 17 years. But the really hard part is the treatments that we can implement at big academic medical centers, we need to make sure that those treatments actually reach communities that are far away from us and that may not have the same resources that we have. So what can we do today that can help families who are affected with Lynch syndrome reduce the burden of this disease? So you heard earlier, Lynch syndrome is actually really common. And when I started working with families with Lynch syndrome more than 25 years ago, most people had never heard of Lynch syndrome. I think we've come some way, but we have a long way to go yet, because 1 in every 279 people has a gene change associated with Lynch syndrome, and most folks don't know that they're at risk. How do we find families who would benefit from this extra screening and extra prevention for cancers? Well, my answer is we have to search systematically. We have to not only look for the tip of the iceberg, but we got to figure out ways to be able to identify everybody who's flying below the radar or below the surface of where we're looking. And so in cancer genetics, we know that there's a lot of things that determine whether a person or family gets identified as needing genetic testing. We know tremendously that provider recommendations. So if a clinician actually talks to a patient about the cancer risks in the family and recommends genetic testing, people are more likely to have genetic testing. But there are also factors that are related to an individual's background, their level of knowledge of genetics, their comfort with going to a healthcare system, for going to a specialized clinic, for talking about possible hereditary cancers in families. And there's also a number of system constraints. So before the pandemic, it was very, very hard for people to travel to genetics clinics. And now that we have virtual care and telehealth, things have gotten a little bit better. But in the state of Michigan, where I work, we also know that more than 80% of individuals who undergo genetic testing in Michigan happen to be women who came in because of their personal or family history of breast cancer. So we need to move beyond this. And I think our advocacy partners who are here today have done an amazing job at getting people to talk about colon cancer and to be able to think about colon cancer as having a potential genetic implication, and not just family history of breast cancer, but family history of colon cancer and other cancers as well. Because as we've talked about, Lynch syndrome goes beyond colon cancer, which is why we changed the name from hereditary non-polyposis colorectal cancer to Lynch syndrome. But in the state of Michigan, in partnership with my collaborators, Dr. Jennifer Briggs and Dr. Ken Resnikow, we were really fortunate to have been awarded one of the Biden Cancer Moonshot grants for a project that was looking at innovative ways to help expand genetic screening and testing to families throughout the state of Michigan who were flying under the radar for hereditary cancer susceptibility. And so we said, we're going to focus on provider and patient-based interventions. And so for the provider-based intervention we're going to help people collect a family history. And we're going to make sure that patients who come to see their doctors in community oncology clinics, as well as gastroenterology clinics, as well as primary care clinics, are going to be able to provide their doctor with their family tree. It takes time for a clinician to take all this history and draw these family trees. But through this tool, patients can fill out their family history and it draws the tree for you. And it even calculates a risk model prediction as to what the level of risk is for Lynch syndrome. And we know from some of the work that's been done in developing risk models for Lynch syndrome is that the PREM5 score is very helpful in identifying who meets criteria for genetic testing. So anyone with a PREM5 score of at least 5% would meet criteria for genetic testing. And recently we know that 2.5% is probably a good threshold to go to as well. But then the patient-facing interventions actually focused on, once we've identified families who meet criteria for genetic testing, how do we get them to get tested? And so we made a clinical trial where people were either usual care, which is we said, thank you so much for filling out this family history tool, talk to your doctor about this. Or we actually did 2 levels of intervention where in one arm, we gave individuals access to a web-based tool that provided information about conditions like Lynch syndrome and how to get tested. These are the clinics near you that could do your testing. And then the final arm, we had individuals get phone calls from genetics health coaches who were able to talk to them a little bit about why genetic testing was important. And I think that what we did as part of this study was we tried to talk to families with Lynch syndrome about what concerns they had before having genetic testing and what concerns they had encountered among their family members, because once there's a genetic diagnosis in the family, it's so important for family members to get tested. And we identified several areas where we can actually provide more information, both about not only about what Lynch syndrome is and what other genetic conditions are, but ways that patients and families can advocate with their healthcare professionals and advocate to try to get the care that they need and overcome some of the reluctance or hesitancy for testing. And we know that this is so important because we know Lynch syndrome is common. We know that most people are undiagnosed. And we also know that in most families with Lynch syndrome, not everybody gets tested for Lynch syndrome because not everyone wants to know. And I think that being able to overcome that fear and being able to provide effective strategies that can help family members with Lynch syndrome talk to their relatives about why testing is important, and also hopefully overcome some of that burden with having to convince your family members that they need to get tested and letting us help work with you to figure out how we can move the needle to get more people tested and in the prevention phase for this condition. So I think in summary, the road ahead. A few years ago, Time magazine had this cover that basically said why your DNA isn't your destiny. And I think we're all here today because we know that if we know what we're looking for with taking care of families with Lynch syndrome, we have a much better chance of being able to reduce the impact that cancers have in families. We know that the road ahead is going to involve education of patients and families and clinicians. We know that implementation of the interventions that work. We know taking a family history is so important, and we can identify so many families with Lynch syndrome just based on family history. We also know that once we have patients with Lynch syndrome in our clinical system, we can do high quality endoscopy, which does work. It's not perfect, but it does work. But maybe there are other tests that we can add that can help this work better. Chemo prevention, aspirin, we can start taking aspirin. Baby dose aspirin has very little in the way of side effects. And certainly talking to your doctor about what other treatments may be right for you. Access to genetic services, making sure that this is equitable and that people who don't get their care in centers like University of Michigan or University of Colorado, making sure that these folks can benefit as well without having to travel. And finally, investigation and discovery. We've talked a lot about how cancer risks differ among different families. Are there modifiers of cancer risk that we can identify that can help us more precisely determine how often people need colonoscopies and how we can make these more effective? Also immunoprevention. As I told you, I think immunotherapy is where it's at. And when I went to medical school, what we knew about what the immune system did is such a tiny part of what we know now. And I think that the collaboration among multiple disciplines in figuring out how we can leverage the power of the immune system is really where we're going. So primary prevention, what can we do to keep ourselves healthy and starting young when we can make the most benefit to last a lifetime? So in closing, I just wanted to thank Dr. Swati Patel for having us all here today. And also wanted to shout out what you'll probably hear about a little bit more, which is Dr. Patel's really impressive initiative, Lineage, which is actually seeking to be a partnership between institutions that take care of families with Lynch syndrome and patients and families with Lynch syndrome, to be able to bring together the data that we need among our families in the US to figure out how to better care for our families and how to move forward these discoveries that accelerate the pace of the discoveries that we've been talking about. Because ultimately what we want to do is for families like Family Z, where you see cancers marching through generations, we want to actually make those cancers stop. We want to be able to make sure that we act early and act effectively. So on that note, I want to thank you so much to Dr. Patel and her team for inviting me to join you here today. Thank you all for taking time out of your schedule to be here. And thank you to the patients and families who participate in our research studies, as well as your continued advocacy for this research, because none of this could really be able to continue without the support of National Institutes of Health and other funding sources. So thank you all so much.
All right. Can you hear me? Okay. Thank you so much, Dr. Stoffel.